So we are going to go ahead and I'm going to ask you to mute your phones until we begin the Q&A portion. But that being said, there's not a lot of people on the call. So if you have a question about one of the slides, I'm okay with you jumping in and making it interactive. First, I just want to thank everybody. I know how busy you are. Thank you for taking your lunch and sharing it with public health. This is a Zika update for healthcare providers, mostly in Maricopa County, but also Arizona.
Let's see if they can see the screen.
And, oh, can everybody see the screen okay?
Yes.
Great, okay. So mostly what I'm here to do is give you a very brief overview, an update of what we know about, just information about the congenital effects, available testing, and then to get some feedback from you all about what we can do to better support you out there on the front lines. So, it's not working. Okay, there we go. Just click it. Okay. So just a reminder that Zika virus is a flavivirus, and this is a list of all the related flaviviruses that are out there. The main one I want you to take notice of is dengue, because this is basically the reason why Zika diagnostic testing is so challenging. And we'll talk a little bit more about that later. In general, Zika was first discovered in 1947 in the Zika forest in Uganda. Before that time, it typically affected only non-human primates, and it was carried by this particular mosquito's Aedes africanus. The very first outbreak in humans was noted in 2007 in Yap, Micronesia, and that's where we have our original epidemiological information about Zika. That's circled here on the map. So if you look at that, you can see why it ended up being hitting that eastern side of Brazil in 2015. That's where it was first noted to have hit the Americas in May of 2015. May through July, they noticed an increase in Guillain-Barré cases in Zika-affected areas. And then approximately 9 months later, they did note a large increase in microcephaly. And then Zika spread rapidly through South America. And it wasn't until that time that they actually went back and looked at the outbreak in Yap, Micronesia, and did a retrospective look for an increase in microcephaly, and they did find that there was an increase. So it rapidly spread through Brazil and up north through South America, Central America, and Mexico, and right to our border state in Sonora. So Zika in the United States, this is as of January 18th, there were 4,900 confirmed cases, almost 1,400 pregnant women with any laboratory evidence of Zika virus, and that is a very vague statement. It really is any positive or equivocal test associated with Zika. There have been 38 sexually transmitted cases and 13 noted cases of Guillain-Barré believed to be associated with Zika in the U.S. Almost 5,000 travel-associated cases. I think the important thing is that there have been 217 locally acquired cases. 211 of them are in Florida, 6 in Texas, and then 1 laboratory-acquired case. If you look at the U.S. territories, there are many, many more cases in Puerto Rico and the U.S. Virgin Islands, and they have also noted an increase in Guillain-Barré. Texas was identified in November of 2016 in the Rio Grande Valley that they had some local spread, and that was along the Mexican border as well. And as of 12/9/2016, there is no more ongoing transmission in Florida, and they have done a lot of enhanced surveillance, so I really believe that statement. So when you look at Arizona, this is as of 12/30/2016, we had 53 cases in Arizona. 35 or 65% are in Maricopa County residents. More than 800 cases have been investigated in Maricopa County, and these numbers do not include almost 100 pregnant unaccompanied minors who have traveled up from Central America through Mexico into Arizona and ended up in shelters here in Maricopa County. Of those roughly 100 who we've investigated, 7 of them have had positive testing or equivocal testing for Zika. These individuals offer all kinds of different challenges, both for the healthcare providers and for public health, because they don't always have a routine provider. When they're in the shelter, they have one provider. When they are reunified with their sponsor, they will often get a different provider, and they often don't have access to insurance while they're waiting to get on access or Medicaid. So there are a number of different issues with them, and I'm interested in hearing your feedback regarding taking care of these unaccompanied children as well. This is a map that I have from October. The reason I didn't put the latest map up is because everything kind of restarted in January, and it makes it look like there's no Zika in Mexico because there's only been a couple weeks worth of data. But this is the map that we're getting every week from our border infectious disease surveillance folks. And what you can see is the darker the color in Mexico, the more cases that they have identified, and these are only locally spread cases. These are not travel related. And when there's a teal border, it indicates that there's been a case in the last week. They have not identified any cases in Sonora over the last couple of weeks. That being said, there have been cases in Sonora, Mexico, located in 2 different clusters. So, on September 22nd, 2016, right in the area of San Miguel de Orjasitas, which is a small agricultural town of approximately 300 persons, they were able to identify 3 confirmed cases, 9 epidemiologically linked, and 8 pending at the time of this investigation. At that time, they believed that transmission dated all the way back to July. Why is that important? Well, it took them 3 months to identify that transmission was occurring. And it's important to know that we're not quite as aware of what's being done regarding surveillance in Sonora. So we're told that surveillance is being done, but we also got notification just a few weeks after this first cluster was identified that transmission was over. In the United States, we wait a minimum of 2 incubation periods before we declare anything to be over, and that would be a minimum of a month. So we're not as confident in the surveillance data that we're getting from Sonora, Mexico, that we might be from our own system in the United States. So that being said, I think there is likely still transmission in Sonora, Mexico. So you're all aware that Zika transmission is primarily via mosquito, and here it's mostly Aedes aegypti. We don't have Aedes albopictus here, but Aedes aegypti is the primary vector. It also occurs perinatally, transplacental, and peripartum, and through sexual transmission. Important to know that it does not matter if the person is symptomatic or not. It can still be transmitted sexually, but it is mostly from male to female. There is probable transfusion-associated Zika. We haven't identified any in the U.S., but there's well-documented transmission via platelet transfusion in Brazil. In the French Polynesian outbreak, 2.8% of blood donors did test positive for Zika. And in case folks aren't aware, our United Blood Systems, all of our blood donations are tested with a Zika NAT test, which is actually provisionally approved by IND. So it's not approved for patients, it's just approved for testing the blood supply. And we have had several positives in the blood supply thus far. There is some speculation that other body fluids might be infectious. There's one individual where an elderly gentleman who was dying from other causes is believed to have transmitted it to the caregiver, and the main contact was with tears and saliva, but that is one case. Little bit about the incubation period in viremia. The incubation period for Zika is 3 to 14 days. Viremia ranges from a few days to about a week, but I'll show you some information later. We know now that pregnancy can prolong that viremia even up to many weeks. We know that virus remains in semen longer than in blood, and it has been detected in semen up to 188 days after symptoms, with an average of 90 days in a small sample. That detection is by PCR, so we don't know that it was viable or able to infect someone else. But virus was cultured in semen up to 69 days after symptom onset, so that we know to be viable. And that is the basis for the recommendations from CDC about how long for men and women to wait until attempting to conceive or having sex with a pregnant woman. Just a reminder, I left this slide in here to remind you that Aedes aegypti mosquitoes are widespread and thriving in Maricopa County, and to remind you that the mosquitoes that transmit Zika are different than the mosquitoes that transmit West Nile virus. We're used to saying avoid being outside without protection during dawn and dusk, but these mosquitoes are daytime biters. They do bite around the ankles, so it's really important to wear socks in addition to mosquito repellent, and they are backyard breeders, and they can breed in containers as small as a thimble. So any container, backyard, plants, tires, all of it can breed these mosquitoes. These are some examples of the containers. We worry a lot about toys that are sitting outside. And this is just a map from 2012 to 2014 to show you all the different places that Aedes aegypti has been identified in Maricopa County. All of those red dots were just 2014, so there is no place, urban or rural, that is spared from this vector. So the symptoms, I think you all know that only 1 in 5 individuals infected with Zika actually has symptoms. The vast majority who have symptoms, more than 90%, have a maculopapular rash. That's probably the only one we see reliably. About 2/3 have a low-grade fever. A little more than half have myalgias or arthralgias. About half have a headache, and about 1/3 to a half have a conjunctivitis, and under 50%, 40% have retroorbital pain. And that's based on several different studies that are out there. The differential diagnosis includes dengue and chikungunya. Just a reminder, chikungunya is not a flavivirus, so it doesn't cross-react like dengue does, but it does present very clinically similar. And then these other diseases can also present similarly. This is one of my favorite charts, and this should remind you that whenever you're worried about Zika, you also want to test for dengue and chikungunya. That's the reason why they've developed the trioplex test, where you send one specimen and you get the results for all 3 diseases at the same time. The state laboratory does offer this test, as do many commercial laboratories. So what's important about this slide is to note that you almost always see a rash in Zika. You can see a rash in the other 2 diseases, but those 3 pluses in the rash are important. And if you do see conjunctivitis, that differentiates Zika from the other 2 diseases, which do not present with conjunctivitis. It's also a reminder that if you see any hemorrhagic symptoms, shock, petechial rash, then it's much more likely to be dengue than the others. So I want to share with you, there's very minimal literature thus far on congenital Zika syndrome and Guillain-Barré risk, but I wanted to share with you what I've found in the literature. So current estimates for congenital Zika syndrome risk after the first trimester infection, and this is, they're not divided neatly into any trimester. So after the first infection, the ranges are from 0.88 to 13.2% likelihood that there will be some type of congenital abnormality. We know that the incidence of microcephaly in Brazil went from approximately 6 per 100,000 live births in 2014 to 117 per 100,000 in 2015, and I'll show you a visual so that you can be very confident there's a definite significant increase after Zika was introduced. And the one number we have for Guillain-Barré is that 0.24 Guillain-Barré syndrome cases per 1,000 Zika infections occurs. So it's an increased likelihood from not having Zika, but it's still a fairly low risk. And as you know, Guillain-Barré syndrome also occurs with multiple other viral infections and bacterial. So the congenital effects of Zika, I think one of the biggest studies, this was in the New England Journal, is a study from Brazil of 72 pregnant women with documented Zika virus infection, and they were infected anywhere from 6 to 35 weeks of gestation. Only 42 of them actually had ultrasounds performed, but of the 42 that had ultrasounds, 12 or 29% of them had evidence of intrauterine growth restriction. 17% or 7 of the 42 had microcephaly, cerebral atrophy, or brain calcifications, and there were 2 fetal deaths. There was also a retrospective study from French Polynesia that estimated that 1% of fetuses born to Zika-infected mothers in the first trimester had microcephaly. So I think what I take from this is the absolute, probably maximum percentage of pregnancies that where a Zika-infected mother is going to have a baby with a severe abnormality. Probably the top range is 29%, but it's probably somewhere down between 5 and 20%. Probably in the lower ranges. We just don't have good data yet. We do know that it can occur with infection in all trimesters. I'm sure most of you noted we used to say, well, it's probably just the first and second trimester because it affects brain growth, but we now know that there is actually delayed onset microcephaly when they're infected in the third trimester, and brain growth is affected after birth. There's one study in the U.S. of 70 infants with Zika virus infection and microcephaly aged 0 to 10 months, and they did show that about 6% of them had sensory neural hearing loss, so we do know that hearing is affected. There was evidence of ophthalmic lesions leading to macular atrophy, orthopedic lesions, and we believe that there is a large clinical spectrum that we have not yet been able to fully describe. This is that visual of the number of microcephaly cases in Brazil leading up to 2015 based on the area of Brazil, and you can see that there's definitely a significant increase even without the statistics there. So the main goal of today is to make sure that you all are aware of the recommendations to prevent congenital Zika and to keep pregnant women and women of childbearing age from getting infected. From what we know, the longest period from sexual transmission is 32 to 41 days after infection. Again, that is why we ask men to wait 6 months prior to attempting to conceive and to withhold from unprotected sex with a pregnant woman once they've been infected. And that is regardless of symptoms, again, so it doesn't matter if the man has symptoms, and that's why if they actually even travel to a Zika-affected area, we ask them to refrain from unprotected sex for 6 months with a pregnant woman or woman of childbearing age. Women with confirmed Zika virus infection or exposure should wait at least 8 weeks prior to attempting conception, and that's because the virus does not stay in the women's reproductive system in the same way that it stays in the semen, and that's only true for non-pregnant women. Couples who reside in a Zika-affected area should consider using barrier contraception methods or abstinence while active transmission persists. The testing is very complicated, and I'm happy to answer any questions, but what I want you to walk away with is that Zika testing is available and free from the Arizona State Public Health Laboratory for patients that meet testing criteria, and I'll talk about who those are in just a minute. You can contact the county health department to request laboratory testing. Order PCR in the first 2 weeks after symptoms, and if you're testing a pregnant woman, within the first 2 weeks after exposure. That's the big take-home point, is if it's within 2 weeks of exposure in a pregnant woman or symptoms in a non-pregnant person or male, then you want to get PCR first. And for PCR, we ask you to collect whole blood and urine. Whole blood is actually better than serum, and urine is also better than serum. We do ask that you collect serum as well, because if the PCR is negative, we're going to ask you to go on and order an IgM 2 weeks after, for greater than 2 weeks after symptom onset or exposure. And that's really the only way to rule out Zika virus infection if the PCR is negative, is having a negative IgM. So ordering, and then the IgM can only be done in serum, and you can see why this raises issues. It'd be nice if we could just get the serum and you could perform the PCR on it and then do the IgM, but again, serum is not very good for PCR. Urine is far better and will be positive for up to 2 weeks. I think everyone is aware of the issues with IgM. It does cross-react with other flaviviruses. The flavivirus that we need to worry about the most in most countries that Zika circulates, dengue also circulates. There's also yellow fever and some other issues, and of course we have West Nile virus here, and it may or may not be in the countries where these individuals were exposed. Another note about IgM, because of the cross-reactivity, we have to confirm it with a PRNT, or plaque reduction neutralization test at CDC. This process takes weeks to months. Public health will coordinate it, but it really causes issues clinically while we have these cross-reactive IgMs that are positive. It's hard to know what to tell patients. And I will tell you that we thought PRNT was very specific in the beginning, but we're learning that PRNT does also cross-react, and you can't even necessarily tell if someone has been exposed to dengue. It can make the PRNT for Zika actually appear even higher. So you can't necessarily tell whether it's truly due to Zika just based on the PRNT, and we're seeing a lot of equivocal PRNTs where we basically have to tell the individual it might be Zika, it might be dengue, and that's very challenging. Again, if you get a negative IgM result, Zika is essentially ruled out. I think that's the best thing to remember for individuals who have traveled there and want to conceive. Getting that negative IgM is very reassuring for them. Viral RNA is detected by PCR. Just to repeat, the viremia typically lasts about 1 week. You can do it in serum or whole blood. Whole blood is definitely better, and Zika virus persists in the urine for up to 14 days, but that's why we ask you to collect all 3 specimens. IgM antibodies for greater than 14 days. We talked about the cross-reaction. PCR is very specific. It is terribly insensitive, and we know that because of a study that Florida did. They looked at urine versus serum in 66 infected persons in Florida, and I just want to highlight that first bullet. Of 61 specimens, 92% of the urine specimens were positive by PCR, and less than half of serum specimens were positive, and that's why I really don't rely on serum for PCR anymore. And there was not a single positive sera after 5 days post-symptom onset. They were able to identify Zika in the urine up to 28 days, but really it's only reliably in there for up to 14 days. Again, a negative PCR does not rule out Zika, and we need to follow it with an IgM. PCR and IgM testing are available from public health for those who meet criteria. We'll talk about that in a minute. But they're also available from most commercial labs. The only test you can't get from a commercial laboratory is that PRNT, which only CDC will do, and there is a longer turnaround time for that reason. There have been false positive commercial PCRs reported. I know you think of PCR as never being false positive, but they do exist. And if you've got somebody with a positive PCR that they didn't travel, or there's something about it that you just don't buy it, call us and we can work with you to go ahead and confirm that with a test at the state laboratory. Especially in somebody without travel, we very much want to confirm that. So again, a Zika positive test in a person without travel or a history of a sexual exposure, please call us and we will confirm that with you. We've had those already. So our testing priorities in public health are basically the people who are at the greatest risk of having issues from Zika, and that's pregnant women and women of childbearing age and people who have traveled to known Zika affected areas. So symptomatic cases with 2 or more symptoms and recent travel within 14 days to a Zika affected area, we will test. And that includes sex with a Zika infected partner. Anyone who's pregnant with or without symptoms and known travel to Zika affected area or sex with a Zika infected partner, we will test. Any pregnant female with ultrasound evidence of microcephaly or intracranial calcifications. We'd like you to rule out the other torch infections before we do Zika testing, but we're happy to do it. And an infant born to an infected mother or with microcephaly, and a mother who is known to be exposed to Zika. And any other requests, please don't hesitate to call us. We'll work it through with you on a case-by-case basis. This is the testing algorithm. I'm not going to walk through it with you. They're all predicated on the concept that within 2 weeks of exposure or symptom onset, you want to test by PCR. After 2 weeks, you want to get an IgM. IgM, if it's negative, basically rules it out, but a negative PCR needs to be followed by an IgM test. Just to note that there is known to be prolonged viremia in pregnancy. There was a small study among 5 pregnant women in the U.S., 4 of which were symptomatic, and they found RNA detected in the serum up to 46 days after symptom onset, and 1 asymptomatic pregnant woman had it almost 2 months after exposure. This is thought to be due to delayed immune clearance of the virus due to altered immunity in pregnancy, or possibly fetal infection and ongoing viral replication in the fetus or the placenta. It's still unknown, but we do know that you have a higher likelihood of getting a PCR positive in a pregnant woman in the serum or the whole blood for longer. And this is the testing algorithm for pregnant women. All of these are on the Arizona Department of Health Services website that we have at the end. And this is the algorithm for follow-up of pregnant women. Basically, if there's any positive, inconclusive, or equivocal test, fetal ultrasound is recommended every 3 to 4 weeks to assess fetal anatomy and growth. And then infant serum, urine, and whole blood within 2 days of birth. So we're going to ask again that you report to public health anybody who has a positive Zika test who doesn't have travel, anyone with a rash, especially if they have a rash plus 2 other Zika symptoms, and those symptoms are fever, joint pain, and or conjunctivitis and rash. So if they have a rash plus 2 of those 3 symptoms and a high clinical suspicion of Zika, regardless of travel, we definitely want to hear about it because that's how we're going to pick up local spread. Any questions you have regarding Zika testing availability, interpretation, or other assistance, please call us. And any questions regarding which areas are affected with Zika, we may have more information from our public health route. Those detailed testing algorithms are located on the links below, and we're happy to send out these slides. And these are our phone numbers Monday through Friday and nights and weekends to report any issues and to ask us any questions if you need assistance with Zika. And this is specifically for Maricopa County, but we have access to all the county numbers if you need them. So the take-home points for you guys: educate your pregnant women and women of childbearing age about the Zika risk during travel to Zika-affected areas, including Mexico, also with partners who have traveled to those areas. If travel can't be avoided, please tell them to avoid mosquitoes and unprotected sex for 8 weeks following their travel. And when they return, if they were exposed, please offer pregnant women Zika testing within 2 to 12 weeks of the last exposure. After 12 weeks, there's really no testing that can be done, so we prefer that you get them referred to us within the 12 weeks. And please call us with any Zika questions. We do need your help. We need you to call us, not just with questions for us, but with challenges that are arising from the field. You all are on the front line. We've heard that some of the guidance is confusing. There's barriers. Please tell us what they are so you can help us better support you and your patients. All right, do you have any questions for me?
I do have a question. There is a program called Southwest Key. This is for the refugee children from Central America who had come without parents.
Yes.
And MIHS is running a clinic to provide them primary care. I'm not sure if there is any Zika testing in. I know that there had been some pregnant teenagers, and these are very abused children. I will actually inform the medical director of that clinic to contact you on your email, which is here, see if something should be done there.
So thank you for doing that, and we'd love for you to reach out. We have actually been in direct contact with Southwest Keys, and a number, I mentioned that there were about 100 unaccompanied minors. Those are the kids that you're referring to. So many of them know to call us when they identify a pregnant minor who is there. But any communication you can do, and especially the docs that are providing primary care, We want to make sure that they're tested. We're also working closely with the Office of Refugee Resettlement to make sure that they get their test results even if they're reunified with their sponsors. We're actually having a call on Friday with ORR National and the Arizona Department of Health Services to make sure that process goes smoothly. But anything you can do to help make sure that they know that we're running those tests. We'll even go to the clinic and collect specimens because we know it's been challenging. Thank you for that.
Now this virus, Aedes aegypti, I remember from medical school many years ago. Does it cause some other infections?
So Aedes aegypti is the mosquito vector, and it is the same vector that carries chikungunya and dengue.
Okay.
Yeah. So when we were having an outbreak of dengue in Sonora, Mexico, we did a lot of and chikungunya actually in Sonora, Mexico, and we had some down in Yuma County. We did a lot of increased monitoring for Aedes aegypti, and honestly, we're fortunate for that. We never had large outbreaks here. We never had anything more than travel-associated cases, but we have a very robust Aedes aegypti surveillance system because of those issues in Mexico. So we were sort of ahead of the 8 ball when it came to Zika surveillance. And I don't want to take all the credit for that. We work very closely with Environmental Services, who does all of the mosquito testing, and when there is a test ordered anywhere in the community, we immediately call Environmental Services and they do an environmental inspection, and we let folks know about the prevention measures for preventing mosquito bites and also getting rid of containers in their yard. Any other questions, comments from the group? All right, I'm going to prompt you with some questions. Were folks on the phone, were you already aware that Zika was circulating in Mexico and specifically in Sonora?
No.
Okay, that's what we're afraid of, is that people who go to places in Sonora, maybe back and forth in Nogales, people who have family there, maybe even Rocky Point, aren't aware that there's any Zika risk across the border. Any others? Has anyone heard that there was Zika in Sonora? Okay. So if you weren't aware, your patients probably are not aware either. That's one of the big points of this webinar, is making sure that you all inform your patients who travel back and forth. How about the guidance you're getting from public health, specifically from CDC, Arizona Department of Health, and us regarding Zika diagnosis and management? Are you aware of that guidance?
I have seen the communication from CDC.
Any others? Okay, and are there any specific barriers that you've noted in getting eligible patients tested by public health for Zika? Okay. Well, if you note any specific barriers or questions come up, or there's questions about the literature that's out there, if it appears to be conflicting, which some of it is, we very much encourage you to contact us. And again, here's my email and the website. There we go. And a number that you can call anytime you need assistance with Zika virus testing. Also, if you have colleagues that weren't able to make this webinar, we're going to record it and have it available. And I'm also happy to share any of these slides if you want to share them with any of your colleagues or present them at your clinics.
Rebecca, yes, I have a question. Is Dr. Patty Graham from DMG just attending this?
So I sent her an invite, but she is not registered.
So she would be a key person because of the almost all the OB cases coming through MIH system. She and Dr. Coonrod are the leaders for that, so it might be helpful if this information be sent to them, and I will let them know. This is Dr. Kurval. I'm with DMG and the
Great.
MIHS. I will give your contact number and information to Dr. Coonrod.
I will forward you the slides directly.
Okay.
If you could share it with them.
That'll be great.
Okay, and then we're also...
I have your email, so after we finish, I will send you just a contact email so you can reply and send the slides, and I will send it to them.
Fantastic. That is one of the main groups we were hoping to get a hold of OB at MIHS. So we just want to make sure they know who to reach out to. And we know that there are some potential systems issues, especially with those unaccompanied minors, and we're happy to work through any of them.
You know, the other will be the Association of the Community Health Centers, like Mountain Park and Clinica Adelante. They do a lot of OB.
Yes, so we have actually some folks from Adelante had registered for this, so they will be getting the slides as well. And we did invite all of the federally qualified healthcare centers, and we hope that just by sending out the slides, at least they'll be able to review them afterwards.
Thank you.
Thank you. Any other questions or comments from anyone?
Yeah, Rebecca, this is Vince over at Correctional Health. How are you doing?
Great. How are you, Vince?
Hey, great. I was wondering if you could send those to me, and that way I can share with our providers here.
You'll get your own personal copy.
All right, hey, thank you.
You're welcome. And the webinar, we'll also send you a link to the webinar recorded in case you want to talk it through.
Okay, good. Thank you.
Mm-hmm. All right. Thank you, everyone, for your time. I really appreciate it.
Thank you.
All right. Have a great day. You too.
All right, bye-bye.
Bye-bye.